talk to us about quality of life after surgery for rectal cancer.
Good morning, everyone. Thanks for the invitation to this nice night meeting. And the title of my talk is The Quality of Life After Surgery for Rectal Cancer. Is the green one? Okay. One of the most used definition of quality of life is the WHO definition. That is the perception, the quality of life is the perception, the individual's perception of their position in life in the context of the culture and the value systems in which they live, and in relation to their goals, expectations, standards, and consent. It is a broad-ranging concept affected in a complex way by the person's physical health, psychological state, personal beliefs, social relationship, and their relationship to salient features of their environment. When quality of life is applied to the medical science, is named health-related quality of life and refers to how a disease or a medical condition affects the life of patients. The traditional outcome in oncology has been for many years the overall survival, disease-free survival, local recurrence, disease-free survival. There has been a shift in this outcome. Now, the patient's reported outcome are as important as the traditional oncological outcome. And you can see that in the number of articles in this field has been tremendously increased in the last 30 years. For the purpose of this talk, I and my colleagues, we reviewed the article published in the last 5 years, focusing in health-related quality of life after surgery in patients with rectal cancer. We made a systematic literature search on PubMed from January 2009 to November 2013, all the articles published in English, and the term searched were rectal neoplasm and quality of life. In order to have more homogeneous data, we considered, first of all, the clinical significance of the data. Clinical significance was a difference of at least 10 points for the instruments using a score from 0 to 100. For instrument user, other score range, we still considered the traditional statistical significance. We retrieved potentially important article in 477 after excluding article without primary data, no quality of life data, included patient with no rectal cancers, low sample size. We identified 56 articles. The majority of the articles were dealing with surgical procedures, were comparisons between surgical procedures. The most frequent comparison was between sphincter saving and the non-sphincter saving procedures, 9 articles. Then stoma versus no stoma, then open versus laparoscopic surgery. In 20% of cases, the comparison was made between multimodality therapy, and most of them were surgery alone versus preoperative chemo or radiotherapy. In 21% of cases, the studies compared results, compared patients with the general health population. As you can see, more than 80% of the studies were observational, cross-sectional in more than 50% of cases, and in 2/3 of the article where the studies were controlled. All the articles were prospective cohort. 60% of the studies included more than 100 patients, and half of patients included in the article had received preoperative chemo or radiotherapy. The instruments used were many, but the majority of the instruments used were the generic questionnaire of the RTC 12QC13, the specific questionnaire of the RTC colorectal 38, or colorectal, or the new one, the colorectal 29, and the SF36. Here you can see the studies on comparing sphincter saving procedures versus non-sphincter saving procedures. You can see that the instrument used, the questionnaire used were many, and overall it's difficult to make to summarize the results. That anyway, 4 of the 9 studies found no differences between patients treated with sphincter saving procedures and non-sphincter saving versus non-sphincter saving procedures. Better results, better scores were found in favor of sphincter saving procedures in 3 studies, and in 2 studies the results were mixed. Again, in comparing stoma versus non-stoma patients, many questionnaires used, few articles, just 4 studies, and results more or less the same. No clear evidence that stoma-free patients score better than non-stoma patients. As you can see in some study, you can find the same scale, better in one group in one study, better in the other group in another study. Different is the situation when comparing laparoscopic versus open surgery. There are few articles, but well done, methodological correct study with many patients, and 2 of them, two of the studies were randomized, were within a randomized study, the Korean study and the cohort 2 study, and all the studies were concluded that there is no difference at all between age-related quality of life between patients treated with laparoscopic surgery and patients treated with open surgery. Last one is the comparison between patients who underwent surgery-only treatment and surgery who underwent preoperative radiotherapy or chemoradiotherapy followed by surgery. Of the six studies, we found 6 studies. The majority of them used the URTC questionnaire. And as you can see, in two studies, there were no difference at all between irradiated and non-irradiated patients. In the remaining studies, only some subscale was affected by the treatment, usually in no more than one article, and all the difference that we found when there was difference was in favor of surgery. As you can see, usually the scale affected are social, role functioning, fecal incontinence, sexual dysfunction. In conclusion, we have to be cautious about the conclusion because the quality of the studies in this field is very, very poor. And there are a lot of limitations regarding the methodology of the studies. Anyway, according also with a Cochrane review with a meta-analysis made some years ago, there is no clear evidence that age-related quality of life is better in stoma-free patients compared with those with a permanent stoma. The choice between sphincter saving procedure or non-sphincter saving procedure should be individualized and non-preconceived and should take into account the full informed consent of the preference of the patient. Laparoscopic and open surgery are equivalent in terms of health-related quality of life at any time point evaluated. While there is no strong evidence that neoadjuvant therapy have a negative impact on quality of life, our findings suggest that preoperative radiation has a negative impact in some scale. The most impacted age-related quality of life dimensions are role and social function and the symptoms related to the bowel and sexual function. Thank you for your attention.
Thank you very much for this interesting talk and the information you have shared with us. We would like to discuss your talk with the next presentation.